inflammatory infections or ischemic colitis, whereas painless hematochezia may occur due to angioectasia, hemorrhoids, or diverticular bleed. Whereas weight loss and altered bowel habits may suggest a malignancy. It's important to also evaluate the medical history and risk factors. A patient with alcohol abuse and cirrhosis presenting with the GI bleed may suggest a brisk upper GI source, whereas underlying atherosclerotic disease may predispose to an ischemic colitis. Medications that increase bleeding risk could also be sought, including nonsteroidal anti-inflammatories, aspirin, and anticoagulants. And any recent surgery or endoscopic intervention could point to an iatrogenic cause. A physical examination should include careful attention to vital signs and assessment for signs of hypovolemia, which would help dictate your resuscitation. Careful rectal examination can also help determine an anorectal bleeding source and indicate the presence of melena, which then would also increase the likelihood of an upper GI bleed. If digital rectal exam is negative, but there's a high index of suspicion for internal hemorrhoids or fissure, anoscopy should be performed. So the initial patient assessment, the triaging, risk stratification, and resuscitation should all be performed simultaneously. Certain urgent investigations, including a full blood count, biochemistry tests, coagulation studies, and type and screen should be sent, and initial resuscitative measures initiated. So there's a risk stratification tool called the shock index, which has been recommended to guide ongoing resuscitation as well as further diagnostic evaluation. It reflects the hemodynamic instability of a patient and is relatively easy to calculate. It's simply the heart rate divided by the systolic blood pressure. So in a patient with a shock index that is greater than 1, this indicates hemodynamic instability, whereas less than 1 would indicate a stable patient. In a patient receiving beta blockade, the shock index should be interpreted with caution. All the guidelines mention that risk prediction scores, there are many that are noted in the literature. These should not be used to replace clinical judgment. But nevertheless, patients who are hemodynamically unstable should receive intravenous fluid resuscitation with the goal of normalization of blood pressure and heart rate prior to diagnostic or therapeutic intervention. In addition, patients with significant hematochezia with reduction in hemoglobin levels will require red cell transfusion. Importantly to note that a restrictive transfusion strategy, which we will discuss a bit later, is not applicable to patients presenting with hemorrhagic shock with ongoing active bleeding. These patients may require vasopressor support and even activation of the hospital's massive hemorrhage protocol. So the next step after risk stratification is to localize the source of bleeding. Let's look first at how we do this in the hemodynamically unstable patient. All the guidelines recommend that a CT angiogram should be performed as the first diagnostic test in a patient with hemodynamic instability. CT angiography provides the fastest and least invasive means to localize the site of blood loss before planning any further therapy. It requires no bowel prep and is typically completed in minutes. There are currently no randomized control trials showing the accuracy of CTA in detecting lower GI bleeds, but retrospective studies have shown sensitivity of around 79 to 95% and specificity of 95 to 100%. CTA detects bleeding if the velocity of blood loss is around 0.3 to 1 mol per minute. Therefore, the higher diagnostic yield is seen in the unstable patients. Given that up to 15% of patients presenting as a lower GI bleed may have an upper GI source, one should always consider an upper endoscopy in a hemodynamically unstable patient, unless the CT angiogram has already localized a lower GI source. Some factors that may suggest a higher likelihood of an upper GI source include the history of portal hypertension, peptic ulcer disease, use of antiplatelet medication, or an increased serum urea to creatinine ratio. So in the hemodynamically unstable patient in whom the CTA demonstrates a site of contrast extravasation, the preferred method to achieve hemostasis is transcatheter angiography. Patients should be referred to interventional radiology for embolization of bleeding mesenteric vessels. This should be performed as soon as possible after a positive CT angiogram, ideally within 60 minutes to maximize the chances of successful embolization. Time has proven to be a significant factor influencing patient outcomes. The greater the time delay between CTA and transcatheter angiography, the weaker the correlation between a bleed observed between the two modalities. So giving the interventional radiologist a heads up call even before the CT is performed may be helpful to avoid time delays. So the choice of agent used, whether coils, ethanol-based, or cyanoacrylate, these should be based on operator experience and availability. And the technique that they use to avoid complications involves the use of microcatheters to allow for super selective embolization of the single vasorector at the site of bleeding. Generally, efficacy rates are high and the risks of ischemic complications are low. However, short-term and long-term rebleeding may be a concern. After bleeding control with embolization, a follow-up colonoscopy is indicated during the admission to evaluate effectiveness of the embolization, identify any residual or concurrent bleeding, evaluate for any procedure-related complications, and also if there perhaps is an underlying pathology, for example, a colorectal malignancy might be present. The other option after a positive CT angiogram is performing a colonoscopy directly. So to attempt to control the bleeding. This can be extremely difficult in patients with severe active hematochezia who may not be able to tolerate bowel preparation and whose endoscopic views are obscured by blood. However, in a retrospective cohort study, they did find that patients who had a positive CT angiogram, they are more likely to have a source detected and treated at the time of colonoscopy than those with a negative CTA. But ultimately, if angiography is not possible or not helpful after a positive CTA, then colonoscopy should be performed to attempt hemostatic control, especially considering that the next option may be surgical. And currently, all three practice guidelines have a clear stance that no patient should have emergency laparotomy unless every effort has been made to localize bleeding by radiologic or endoscopic modalities. And this is because of the high risk of morbidity and mortality that's associated with urgent laparotomy. In a UK audit of patients with lower GI bleed, the use of surgery was needed in 0.2% of all their cases. And if it does come to a point where surgery is deemed necessary, attempts should be made to precisely localize the site of bleeding to allow for a limited targeted resection, because a non-localized hemicolectomy has a higher risk of recurrent bleeding compared to targeted hemicolectomy. There are some instances that do warrant direct surgery, for example, if a patient has an aortoenteric fistula or a Meckel's diverticular bleed. So in the setting of a patient that is hemodynamically unstable, guidelines advocate against the use of red cell scintigraphy to localize bleeding. The detection rates are noted to be similar to CTA, but scintigraphy has poorer correlation with findings at angiography. Also, red cell scans are more time consuming. The test requires radiotracer preparation and another 60 to 90 minutes for image acquisition. And this time delay to diagnosis will then obviously result in a time delay to embolization. Obviously, other logistical constraints including tracer availability and limited institutional access are some of the reasons why it's not advocated for in the hemodynamically unstable patient. So we've discussed the management pathway for the unstable patient. Let's look now at the recommendations for a patient who presents with a hemodynamically stable or a stabilized bleed. They have a shock index that's less than 1, they've got no high-risk features. What's the next step? So according to guidelines, stable bleeds should be characterized as being major or minor using a risk assessment tool called the Oakland score. This tool was developed from a national UK audit of patients with lower GI bleed, and it's actually the first score specifically designed to risk stratify lower GI bleed patients, as opposed to other scores that are adapted from upper GI guidelines. It has been externally validated in multiple other countries, And the score itself comprises 7 variables that are routinely measured during initial clinical assessments, that being age, gender, previous hospital admission with lower GI bleeding, digital rectal examination findings, the heart rate, systolic blood pressure, and hemoglobin levels. The score is added, and the patient scoring less than or equal to 8 points at presentation can be safely discharged from the emergency department, is therefore classified as a minor bleed. A patient scoring more than 8 points is classified as a major bleed and is likely to benefit from hospital admission and an inpatient colonoscopy. It's important to remember that 8% of people over the age of 50 who report rectal bleeding will have a lower GI cancer. So if patients are deemed safe for outpatient evaluation, the colonoscopy should ideally be scheduled within the next 2 weeks. So regarding blood transfusion strategies in patients with stable lower GI bleeds, there's no randomized controlled trials specifically evaluating transfusion targets in lower GI bleeds. The data on transfusion targets are extrapolated from upper GI bleed literature. This forest plot was taken from a meta-analysis of 5 randomized controlled trials comprising 1,965 patients with upper GI bleeding, and they found that a restrictive transfusion strategy was associated with lower risk of all-cause mortality and rebleeding. So even despite limited data on lower GI bleeding specifically, the societal guidelines have consensus on this matter, and they do recommend that a restrictive transfusion strategy be applied to the hemodynamically stable patient, using an HP threshold of less than or equal to 7 grams per deciliter to transfuse, with the target post-transfusion hemoglobin being between 7 to 9 grams per deciliter. In patients with active myocardial ischemia, history of cardiovascular disease, a more liberal blood transfusion hemoglobin threshold may be considered. That's below or equal to 8 grams per deciliter. That's used with the target hemoglobin between 9 to 10. So in the hemodynamically stable patient who was either discharged with a minor bleed or admitted with a major bleed, the first diagnostic test should be a colonoscopy, which has advantages of being able to identify the bleeding source, irrespective of the rate of the bleed, and the option of providing directed endoscopic therapy or tissue biopsy. Colonoscopy is an excellent tool, and it provides diagnostic yields of up to 90% for lesion detection, although most instances generally don't require hemostatic interventions. It also avoids radiation and contrast exposure. And despite colonoscopy having relatively low rates of intervention, the value in detecting an etiology of the bleeding is critical. It helps to determine subsequent management, triage, subsequent follow-up the patients, obviously depending on the underlying diagnosis. So prior guidelines had conditionally recommended performing a colonoscopy within 24 hours for stable patients with high-risk clinical features because and this was based on non-randomized prospective studies that had shown endoscopic treatment significantly reduced the risk of rebleeding and need for emergency surgery, as well as hospital length of stay. But more recently, there has been 2 randomized controlled trials that have been published that have shown that early colonoscopy is not associated with an increased rate of detecting stigmata of recent hemorrhage or reduction in the risk of rebleeding. There were also no significant differences in transfusion rates or mortality seen in these 2 randomized controlled trials. So as a result, the change in guideline recommendation is that all stable patients with major bleed, saying that again, stable patients admitted with a major bleed should have their colonoscopy at some point during their hospital admission, not necessarily within the early 24-hour period. So with the changes in timing of colonoscopy for stable major bleeds, there's also a shift in recommendation regarding bowel prep regimens. The previous recommendation for large volume purge protocols with 4 to 6 liters of PEG-based solution over a period of 3 to 4 hours until the rectal effluent was clear. And this was given with or without the aid of an NGT and antiemetic. This has been replaced by recommendations perhaps for lower volume split prep which has provided higher efficacy and improved tolerability, which has been noted in studies. And the recommendation, these recommendations for split PrEP are based on more recent observational and randomized trials. Split PrEP should be the default for patients undergoing elective or next available inpatient colonoscopy after a stable acute lower GI bleed. However, obviously in patients in whom urgent colonoscopy is pursued, the large volume purge protocol may still be required. So just to mention a few practical points when performing colonoscopy in a patient with a recent hemorrhage to improve overall visualization, localization, and safety. Things like the use of water jet irrigation, using a scope with a large working channel for suction and instrumentation. The use of a transparent clear cap can also help deflect mucosal folds and stabilize the tip of the endoscope and help improve visualization, and can potentially help detect subtle sources of bleeding. The clear cap can also facilitate the endoscopic treatment by placing the target of therapy at an ideal and constant distance from the scope. The terminal ileum should be intubated as far as possible to exclude a proximal source of bleeding. And if bipolar coagulation is used, this should be used at a lower power, less pressure, and shorter pulses than what is used in the upper GI tract, and lower flow rates should be used when applying APC compared to the upper GI tract. It's also important for the endoscopist to be familiar with the various hemostatic equipment that is available in the unit. So let's discuss now some of the endoscopic treatment options for a few common presentations. We spoke briefly about colonic diverticular bleeding. We mentioned that most often the bleeding stops spontaneously, but when stigmata of recent hemorrhage related to the diverticular are found, like we see in that first picture showing showing active bleeding at the neck of the diverticulum, B showing a non-bleeding visible vessel at the base of the diverticulum, C showing an adherent clot, and then D showing active bleeding caused by removal of the adherent clot. So that's some of the features that you'd see, or stigmata of recent hemorrhage you might see in a colonoscopy. And the most commonly used therapeutic options include things like through the scope clips, endoscopic band ligation, and bipolar coagulation. Endoscopic treatment with clips can be direct clipping onto the culprit vessel or indirect placement of clips around the neck in a zipper fashion to close the diverticula. The indirect method is associated with higher rebleeding compared to the direct method. Endoscopic band ligation has also been shown to be very safe and effective in several case series. And in one meta-analysis of 16 studies, endoscopic band ligation was more effective compared with clipping to avoid the need for further transarterial embolization surgery. So the downside with band ligation is the need to remove the scope, obviously to attach the band ligator and then re-intubate and find that marked bleeding diverticular vessel. The use of bipolar coagulation is also seen to be safe and effective in patients with stigmata of recent bleeding, particularly in the region of the diverticular neck. With regards to colonic angiectasia, endoscopic therapy is indicated if there's evidence of acute or chronic blood loss. So APC, organ plasma coagulation, is an effective initial treatment modality with good safety profile. For large angiectasia in the right colon, one may consider giving a submucosal injection of fluid before APC to reduce the risk of perforation. Another technique which has been shown to be safe and effective is submucosal injection below the arteriovenous malformation, followed by endoscopic resection and then targeted coagulation therapy at the submucosal feeding vessel. Clipping can be another option for refractory angiectasia bleeding. Patients who are hospitalized due to post-polypectomy bleeding, so a colonoscopy is typically recommended, and endoscopic therapy is indicated when active bleeding is found or stigmata of recent hemorrhage is seen at the polypectomy site. This typically consists of through the scope clips as an initial treatment, but additional options include direct thermal therapy, organ plasma coagulation, and over-the-scope clips. Head-to-head comparisons for these various treatment options are not available. So let's talk now about the management of antithrombotic agents in patients with lower GI bleed, given that many patients presenting with lower GI bleed may be taking any number of these treatments. So we know that, and that can be up to about 30% of patients presenting with a lower GI bleed may be taking anticoagulant or antiplatelet treatments. And the management of these patients often require an NDT approach because you're considering the severity of bleeding, the risk of rebleeding, and obviously the patient's thrombotic risk, and all these things need to be weighed up. So the guidelines recommend regarding warfarin use, if the patient has a minor bleed, so minor bleed, Oakland score less than or equal to 8, he or she does not require any interruption of the warfarin therapy. One should probably just ensure that the levels are not supratherapeutic. Any major bleed, so any patient that's been admitted with a major bleed, according to the Oakland score, requires an interruption in their therapy. And if the patient is hemodynamically unstable, then one would need to correct the coagulopathy with IV vitamin K and prothrombin complex concentrates, which is Semosalvex. And just be careful of vitamin K in patients with mechanical valves who have obviously have a high risk of thrombosis. And they also mention not to delay endoscopic intervention while correcting the coagulopathy. Endoscopic intervention can be performed when patients have therapeutic INR levels. So in patients who are, so once the patient is stabilized, the bleed is addressed, you need to recommence their treatment. So how do you go about recommencing the treatment? In patients with low thrombotic risk, the warfarin can be recommenced from day 7. But if the patient is high risk, they've got a prosthetic metal valve, or they've had a recent DVT or PE less than 3 months, then one can consider recommencing the warfarin after day 3. And initially, one would start titrating low molecular weight heparin before moving on to warfarin. And this should obviously be done in consultation with the cardiologist. So the DOACs very similarly should be continued in a minor bleed and stopped if the patient is admitted with a major bleed. In the event of hemodynamic instability, there are reversals that can be offered, obviously if they're available, and in most instances they're not available. And bear in mind that these drugs have a half-life of about 12 to 24 hours, and most patients will get away with just stopping the DOACs. And also the other downside of the reversal agents is the increased thrombotic risk. So again, once a patient is stabilized, you're planning on restarting the treatment. The DOACs should be restarted from day 7. And in patients with who are at high risk for rebleeding, one should actually consider changing the DOACs to vitamin K antagonist rather. So patients taking antiplatelet medications presenting with acute lower GI bleeding should not be given routine platelet transfusions. If they're taking aspirin as primary prophylaxis, then one can consider withholding the aspirin when they present with the lower GI bleed, and strongly consider stopping the aspirin altogether. So these are people with taking the aspirin as primary prophylaxis. But if they're taking the aspirin as secondary prophylaxis after a stroke or myocardial infarct, here the risk of thrombosis is high, and patients should, as far as possible, continue their treatment unless hemodynamic instability dictates that we stop the aspirin, but then one should resume it within about 5 days. Patients taking dual antiplatelets are usually in the setting of percutaneous coronary stents or in the period following an acute coronary syndrome. And the presentation of the lower GI bleed obviously needs to be weighed up closely with the risk of thrombosis and death. So cardiology consultation is essential. Dual antiplatelets are associated with a 5-fold increase in in-hospital rebleeding, but not with bleeding-associated mortality. But what is noted is that if you discontinue dual antiplatelets within 30 days of a coronary stent or 90 days of an acute coronary syndrome, this is associated with an increased risk of MI and death. So the recommendations are to continue the dual antiplatelets as far as possible. But if severe bleeding occurs, continue only the aspirin and then stop and restart the clopidogrel within 5 to 7 days. So in patients presenting then with obscure overt bleeding where the CTA is negative, they've had good quality upper and lower endoscopy that fails to localize the source of bleeding, one may consider the use of red cell scan. It can offer a diagnosis when the bleed is intermittent, but given the higher likelihood of a small bowel source, video capsule endoscopy should be the next diagnostic modality. 3 randomized control trials support the use of video capsule endoscopy in patients with overt obscure GI bleeding, reporting a higher diagnostic yield than that of small bowel radiography, catheter angiography, and push enteroscopy. The diagnostic yield of video capsule in patients with overt bleeding appears to be highest when the capsule is performed as close as possible to the bleeding episode. If it is performed within 48 hours of presentation with bleeding, the diagnostic yield may be as high as 91%, but this can drop off to less than 50% if performed beyond 3 days of presentation. Obviously, the limitations of video capsule include lack of therapeutic capabilities, inability to control movement through the GI tract, and obviously the potential for retention. This algorithm from the SG guidelines basically summarizes some of the points that I've made today and is a useful quick reference for future if ever you're needing to go back and have a look at that. And so to conclude, acute lower GI bleeding is common, requires prompt patient evaluation, including risk stratification. The choice of initial diagnostic tests should be based on the hemodynamic status of the patient. Fortunately, the vast majority will settle spontaneously. However, with continued bleeding, endoscopic and radiologic modalities should be used to treat the underlying cause. Thank you for your attention, and I'm happy to take any questions.
Thanks, Gillian. Any questions? I see nothing in the chat. Is there anybody with a burning question? Right. Okay, Gillian, let me just maybe ask you 1 or 2 things. The first thing is, in patients who are unstable, and that usually, sort of present with severe lower GI bleed, and with the creatinine that's now 400, you can't do a CTA. What is your next go-to modality of investigation?
So you're probably left with attempting to localize the bleed with the urgent colonoscopy, but that can be difficult as well. I don't think I have a clear answer. But yeah, the risk to the kidneys is there with the angiography, definitely. But potentially that's a reversible acute kidney injury. The contrast risk is there. I think it depends on the situation, I guess, but options of angiography and dialysis. So you want to arrest the bleeding as soon as possible.
Yes. So this is a clinical scenario that probably often will play itself out rather than the other, where everything is kosher and you can just go ahead and do the CTA. Sometimes we just have to resuscitate, make sure that the volume, make sure that they adequately hydrated, even if you have to use central venous pressure monitoring, sometimes that's what we have to do to get that kidney function as optimal as possible. It may not come down to less than 100, or the GFR may not be what you want, but you want to optimize it so that the risk to kidney injury is minimalized as far as possible. Someone in the chat asked, who is that? Let me see. Pascal asked about the role of provocative angiography to increase yield. Do you have any information on that?
Yeah, so it's mentioned in the guidelines. So using heparin or what's this? I forget the name of the other agents that you can use to at angiography to try and induce bleeding, and then obviously once a source is found, then performing embolization. It's something that's obviously recommended as a last resort when other modalities have failed, and the patient presents frequently with bleeding episodes and you're not able to get to the bottom of it. It is there in the guidelines. But again, it's something that's quite, yeah.
Okay, so I don't see any hands up, so I will maybe just ask another one. In the unstable patient, where you have now done everything, so you've done the CTA, you could do all that, you could, you've done your G-scope, you've transfused them to about 9, and you find absolutely nothing on all these tests. Now, what now next? What is going to be your move next?
So we've done the scopes, we've done the CT, we've done the video capsule.
Yes.
We've done all of that, and we still have no source. And this is somebody who presented acutely unstable.
Unstable.
Yeah. Next step. Trying to. So yeah, I don't know if anyone else can venture.
So at this point, this is not for everybody. I think you're gonna have to start thinking about what surgical options do I have available to offer here, and these things come with a lots of mortality and lots of morbidity. But if the patient continues to bleed, I think you're gonna have to do something. And you mentioned that in the beginning that if you have to do an intraoperative procedure to increase your yield, maybe that's the way. That's like an on-table investigation where you put in scopes both directions, opening up the abdomen, have a look, put this, opening up the small bowel, and do bidirectional scopes and just see, because in more likelihood, it's probably going to be a small bowel bleed. If you find nothing in the colon, you find nothing on the top, and that may be an option that you may take, but it comes with morbidity and mortality. Okay.
Yeah. So yeah.
Hi, Ernst. If I can add there, I mean, I think you presented the whole sequence of things. I don't know if you mentioned a balloon-assisted enteroscopy, which is actually, even if the ECE is negative and you've got a high index of suspicion of a small bowel bleed, it is recommended that you can still go ahead with a balloon-assisted enteroscopy, either single or double, whichever you have access to, and you may improve your yield. At the same time, you shouldn't sort of hesitate to redo those interventions, those scopes. Sometimes you may find something on in fact, a significant proportion of the time, you might find something on the repeat scope. Or even what I do is I ask someone else to have a look as well. And even repeat the ECE, because to actually just go and randomly operate on these individuals and hope to find something, is usually, it isn't a great idea. Over the years, I think we've had to do that, like, sort of, I can remember once, we asked the surgeon, we literally had to plead. And there was one occasion we asked like in a private interventional radiologist to do a provocative angiography. And strangely enough, he used heparin, and it actually didn't help anything. We did not provoke anything at all. So yeah, it can be very hard.
And just to flip the coin a little bit, Gillian, what do so for a stable patient, that's easy. If you've done all these tests and they all come back without a definitive cause, in these patients, as you said, what you do is you wait for them to bleed before you reinvestigate them. So that's the easier one out. It's usually the unstable patient where we often have problems deciding what the next best step would be. Here's a question. Here's a question from Nasif. He asked role of repeat endoscopy, and I think Vijay answered that sort of comprehensively. So it's always best, and especially if a patient comes from another hospital, it's often best if you do that upper scope yourself, before you just accept that it was normal elsewhere. Okay. Any other thoughts? I think other than that, I think you've mentioned pretty much. I mean, I think it's fair. It's a fairly comprehensive review, and it's to the point and it's clear. And I think everybody can understand. You need to have an approach, and you really need to know what your next step will be once you've gone through your algorithms, and that's important. I think, and you make that very clear. The definitions are clear. So if everybody's happy, let's just see. There's one more thing in the chat. Thank you. Excellent. Yeah. I agree with I agree with that too. It was an excellent presentation. Thank you, Joe. Well done. And
Ernst, if there's only maybe I wouldn't say it's something I can add for the fellows, is if I recall, this is something that has been asked in exams in the written paper in the past. So it's fairly straightforward, and if you are asked anything on upper GI bleeding, lower GI bleeding, small bowel bleeding, I think if you actually just go over this thing here, this presentation, I think it's more than enough. Would you agree, Ernst?
Yeah, absolutely. Absolutely. Yeah. So Gillian, again, thank you very much. It was sort of well prepared, well presented. And it remains just for me to thank the ECHO of UNM and ECHO India team for the support. The recordings will be available on the Gastro Foundation website, so you can go look at that.
Ernst, I think there's someone who just asked something, now. I'm not sure if we have enough time to answer it.
Is there data to suggest multiple bleeding sites? How common is it? Is that
I did find something that I did find something that mentioned that up to 42% of, but that's, you might find multiple angiectasia, you might find multiple bleeding diverticular, you might find a patient having NSAID induced upper GI lesions and lower GI lesions. So yes, it can occur.
Yeah, so the message is, if you find, especially with angioectasia, if you find one lesion, it doesn't often just imply that's the culprit lesion. You're going to have to, sort of look deeper, even if you have to do a push enteroscope or a double balloon, as Vijay suggested, you may have to look a bit further than that. Obviously, you will co-trace the lesion all the lesions that you find. Right, then
Ernest,
again,
Ernest, can I ask a question?
yeah, go ahead, Nassif.
Yeah, just a question in terms of the usage of Vesco. I know there is a Vesco that we have for lower GIT bleed. I haven't physically used it yet myself, but just practically, I know that's gel indicated. One can band the lesions, but just practically in terms of the usage of an Vesco, is it any different compared to when you use it in the upper GI tract, or any challenges there? Thanks.
No. It's just your position. Well, you will obviously always be compromised because of the colon. In the upper scope, it is easier because you have better control and better stability. It's not as easy. You know what you may well find is that you may want to use the if it's a lesion in the sigmoid or so, to use the gastroscope rather, because you will have better control over that. Sometimes the call scope is just a bit too, not maneuverable very well, and I would certainly suggest, to use the gastroscope to place that ovesco in the colon.
Thanks, Ernest.
Right. Thanks again, Gillian. Thanks everyone for attending and listening and asking questions. And we just have to thank ECHO of the University of New Mexico and ECHO India for their support. The recording of this will be available for you, so you can listen to it anytime. Maybe you can download it as well. And we want to thank the Gastro Foundation for making this possible. The next presentation is next Monday. Don't forget, it's not every 2 weeks. It's just weekly for now until you hear further. Thank you, guys.
Thank you. Bye-bye.
Bye now.